clinical quality measures. Today we have scheduled to cover another 6 of the non-core clinical quality measures, all under the clinical effectiveness and process healthcare domain. However, I did notice that the next webinar, which is scheduled for this Thursday, has only 3 clinical quality measures included in it. So in interest of time, I'm going to go ahead and review those today as well. So if any of you have registered for Thursday's webinar, I'm going to go ahead and cover those today and save you from carving more time out of your schedule on Thursday. I'm still going to hold the session on Thursday and record it as well, but I'll include those last 3 measures in today's session so that you don't have to participate in both of them to save a bit of time in your busy schedules. As we have with all of our other clinical quality measures, we're going to start out with our clinical quality measure dashboard report. It's found under the reports menu. And today we'll be covering the following clinical quality measures. CMS 148, which is also PQRS number 365, hemoglobin A1C tests for pediatric patients, CMS 149, PQRS number 281, cognitive assessment in dementia patients, CMS 158, PQRS number 369, pregnant women that had HBsAG testing, CMS 163, which is PQRS number 2, low-density lipoprotein management in diabetic patients, measure number CMS 164, PQRS number 204, ischemic vascular disease, use of aspirin or another antithrombotic medication, CMS 182, PQRS number 241, another IVD clinical quality measure for complete lipid panel and LDL control, CMS 157, this is one that is scheduled to be covered on Thursday as well, medical radiation oncology pain intensity qualified, that's recording your patient's pain level for your patients going through radiation treatment or chemotherapy. CMS 132, PQRS number 192, for patients with cataracts, complications within the 30 days following cataract surgery, which requires additional surgical procedures. CMS 147, which is also PQRS number 110. This is a carryover from the original clinical quality measures that were first introduced in 2011, preventative care and screening, influenza immunization. As I've mentioned in the other training sessions, under the Help menu, you will find a lot of resources to help you along your meaningful youth path, including the 2014 Clinical Quality Measure spec sheets and guides. The CQM guide is an overview of each quality measure and where it's tracked in ClinicsMD. These CQM spec sheets are the actual specifications provided to us by CMS and goes into detail about the measure, who developed the measure, such as the NCQA, the clinical rationale behind the measure, and the improvement the improvement notation, which is either that a higher score indicates better quality or lower score, lower percentage indicates better quality. These specifications will help you better understand and better use the data that's being tracked in the ClinicsMD for your quality measure performance reporting. As you know, these clinical quality measure reports that were made available in 2014 can also be used to satisfy your PQRS reporting for 2014 by generating the appropriate file format, which you can do by clicking the Generate QRDA button. They will be accepting Category 1 reports. This will be used for both your CMS and PQRS reporting together next year by February 28th, 2015 via the QualityNet Physician Quality Reporting portal. Okay? how that works is that during your meaningful use attestation, you will indicate that you will be reporting your clinical quality measures and your PQRS measures together. You will then be allowed to continue your attestation for your core and menu set measures. They will then hold payment and wait to receive this QRDA file through the QualityNet PQRS reporting portal, and they will then evaluate for payment. Okay? Another great feature that we've built in to use and is available via these specifications that we have in ClinicsMD are the QDM elements, these data criteria in which it breaks out how each piece of the information is being tracked in the measure. For example, if a specific population of patients are being tracked by a specific diagnosis or a specific condition, it will list a value set for that diagnosis. For example, patients who have an active diagnosis of diabetes. It will then provide a code set saying this is the codes or how we're tracking that diagnosis. And they consist of ICD-10, ICD-9, and or SNOMED codes. That allows you to better track the information and better understand how this data is being calculated. To use this tool, let me pull over specification sheet so you can all see it. You'll go through and you'll read all of the information that's provided. Like I said, there's a rationale, clinical recommendation statement, the improvement notation, the denominator, exclusions, and numerator that's being tracked specifically by this measure. Then it gets more detailed and says this is how we outline these patients that have been seen during the measurement period with specific time frames. And continuing down is where you will find the QDM data elements. So for example, if they're looking for specific preventative care services that have been given to a patient, it will say preventative care services. Okay? And then it tells you it's identified by this grouping value set. You can then look this up in ClinicsMD using this value set search tool. Plug in the measure number, the specific value set, and it will return results of how that criteria is being tracked. In this case, it's by 2 different CPT codes. So if the encounter has one of these CPT codes included in it, it would then be included in the denominator for the measure. Okay? Once we go through the measures that we're reviewing today, I will open the floor up to questions as we have during every webinar. In the GoToWebinar menu on the right side of your screen, towards the bottom, there's a section to ask questions. These questions then come over to me and I'll answer them one at a time. So once we're done reviewing these questions today, all of the CMS measures, CQM measures today, I'll then open the floor for questions and feel free to ask me anything you need to regarding your clinical quality measure reporting or any other stage 2 questions you may have. So on that note, let's go ahead and dive right in. The first measure we're covering today is CMS 148, also PQRS number 365. Hemoglobin A1C test for your pediatric patients. This is specifically tracking patients that are aged 5 to 17 years of age with an active diagnosis of diabetes and an office visit between the eligible professional and the patient that predates the most recent visit by 12 months. That's the denominator. Denominator exclusions available for this measure are those patients with a diagnosis of gestational diabetes. If that is indicated in their chart in ClinicsMD, they will automatically be excluded from the denominator in this measure. Patients in the numerator will have documentation of date and result for the A1C test during the measurement period. In this case, it's looking to see if the lab result was indeed resulted, but it's not searching for a specific result. These are being tracked by those LOINC codes, which are used and assigned to your lab order results in clinic setup. Again, to reiterate, if your lab vendor that you have an interface set up with is sending this information, we will go ahead and populate it in ClinicsMD and attach it to your order in clinic setup. Let me briefly show you where that information is stored. In your Orders tab for your lab orders, specific order is listed up here, and the result, which is this is what it's referring to when it's looking for the A1C result. It's not necessarily looking at the order level. It's looking at the specific result. It's looking for LOINC codes, which are laboratory observation codes assigned here. Again, if you have an HL7 interface and your lab is sending this information along with the lab order results, we will pick it up and store it here in your laboratory orders list. If not, you will need to manually assign these LOINC codes for the results. You can do so by doing a quick search. It's just done by description. In this case, this is the one we searched for and attached for this order. And again, using those value set lookup tools, you can look it up for the report and see the LOINC codes established for the specific laboratory test result. In this case, it's listed as laboratory test result, HbA1c laboratory test, using the specific value set. Okay, just to review again how that works. Click Search Value Sets, plug in your CMS number. In this case, from the specification sheets, we're going to plug in this value set ID as identified by the laboratory test result value set ID. Click Search and grab the LOINC code from here. Any one of these will qualify for this report. So again, you can either use the search tool that we built into ClinicsMD or just simply use the specification sheets that have been provided and do a search. Okay. For this measure, the improvement notation is that a higher percentage indicates better quality. So the higher percentage here, the better quality measure, better quality you're giving to your patients. Okay, moving on. Next measure is CMS 149, PQRS number 281, for your dementia patients that have had cognitive assessments. Diagnosis is recorded, of course, in the Diagnosis tab or in the problem list within the RxDX list tab. And cognitive assessments are then documented in the Cognitive Assessment tab that was automatically provided in our 9.0 release. It would be listed under your hidden tabs, and I'll show you that in just a moment. This specifically is tracking the percentage of patients, regardless of age, with a diagnosis of dementia for whom an assessment of cognition is performed and the results reviewed at least once within a 12-month period. Examples of a cognitive assessment include, but aren't limited to, Blessed Orientation Memory Concentration Test, BOMC, Montreal Cognitive Assessment, MOCA, St. Louis University Mental Status Examination, SLUMS, Mini mental state examination, MMSE. Short informant questionnaire on cognitive decline in the elderly, IQ-CODE. Ascertain Dementia 8, 88 questionnaire. Minimum data set, MDS, brief interview of mental status, BIMS. Side note for this one that they've provided is that it's only validated for use with nursing home patients. Or formal neuropsychological evaluation. Diagnosis of a course is recorded in Diagnosis tab. Let's go ahead and open up an encounter. And under the Enable tab, you will find a couple of new tabs that were added, including cognitive status, functional status, and this newly added Refer Transfer tab as well. Okay? The cognitive status would be documented here. And the types, we can do a free search for one of these types. You can search by cognition, cognitive, or again, going back to the value sets, which I know I keep harping on over and over again, is to use the search tool built in to see the specific cognitive assessments. The neuropsych assessments can be documented with a CPT code rather than the cognitive assessment tab. Both of these will suffice for this report. Okay? You can also use the cognitive assessment tab. Look up the corresponding value set for the cognitive assessments performed. And you see here that there's two they're looking for here, and it's based on SNOMED, of course. And you can look these up as well. You can do it by either SNOMED search or description. Okay. Can you do that here? For SNOMED search, just put your cursor in the SNOMED field and type in one of those two codes that was provided. Date performed, results of the assessment, and any additional notes. Entering this information, of course, will suffice for the numerator, or a CPT code indicating that neuropsychological evaluation was performed. In this case, the improvement notation for this quality measure is that a higher percentage indicates better quality of care. Okay. Next measure, CMS 158, PQRS number 369, pregnant women that had HBsAG testing. Indication that the patient is pregnant is documented in one of two ways, either by a specific ICD-9/SNOMED code. And it can also be tracked via the Vital Signs tab in the encounter through one of these pregnancy statuses. is a discrete list that is mapped to this measure. So again, you can either select one of these statuses for pregnancy, or you can indicate via ICD or SNOMED code. The numerator for this measure are any patients who have been tested for the hepatitis B surface antigen, HBsAG, during pregnancy within 280 days prior to delivery. And again, that is tracked by specific LOINC code attached to the result in your order setup. Moving on. Next measure, CMS 163, PQRS number 2, tracking the diabetic patients that have had LDL management, specifically those patients that are 18 to 75 years of age with an active diagnosis of diabetes, whose LDL-C is considered as adequately controlled, less than 100 milligrams, during the measurement period. The clinical recommendation or improvement, notation for this is that higher score, higher percentage indicates better quality. Okay. The diagnosis is tracked via the diagnosis tab in the encounter or in the problem list in the RxDX list in the encounter. Lab results are recorded in the Labs tab as usual. And again, this is tracked by specific LOINC code. Any clinical quality measure involving a specific either lab result value or looking to see if a specific lab has been resulted is tracked by those specific LOINC codes attached to your results. Your panel labs will have multiple results, and a lot of times these quality measures are looking for the value of a specific result in the panel lab, which is why it's broken out in this manner. In this case, the additional guidance they provided for this measure is that the patient is not numerator compliant, meaning they don't qualify for the numerator. They'd be in the listed non-qualified patients if the result for the most recent LDL-C test during the measurement period is greater than 100 milligrams or is missing, or if it wasn't performed during the report period, which in this case will be a 90-day period, October 1 through the end of the year. Next measure is CMS 164, PQRS number 204, ischemic vascular disease, use of aspirin or another antithrombotic. This is specifically tracking those patients that are 18 years of age and older who are discharged alive for acute myocardial infarction, AMI, coronary artery bypass graft, CABG, or percutaneous coronary interventions, PCI, in the 12 months prior to the measurement period, or have an active diagnosis of ischemic vascular disease, IVD, during the measurement period, and who had documentation of use of aspirin or another antithrombotic during the measurement period. So again, for this year, it's going to be a very narrow population since the report period is only October 1 through the end of the year. The improvement notation for this measure is that a higher percentage indicates better quality. the clinical rationale behind this measure is that the U.S. Preventative Services Task Force strongly recommends that clinicians discuss aspirin chemoprevention with adults who are increased risk for coronary heart disease. And that coronary heart disease is a major cause of death in the United States. And acute myocardial infarction being an underlying or contributing cause to death for 156,000 people in 2008. Some of these backtrack and use older data. And the cost associated with cardiovascular disease and stroke in the United States was $448.5 billion in 2008 and is on the rise. So the denominator for this measure are patients that are 18 and up and have one of those active diagnoses, or were inactive diagnoses, of ischemic vascular disease, or who were discharged alive for acute myocardial infarction, coronary artery bypass graft, or percutaneous coronary interventions in the 12 months prior to the measurement period. And the numerator are those patients who have documentation of use of aspirin or another antithrombotic during the measurement period. That is, of course, charted in the prescription tab when the prescription is written for it, or recorded in the medication list in the RxDX list tab. Next measure is similar to this one. It's CMS number 182, PQRS number 241, ischemic vascular disease, complete lipid panel, and LDL control. These are two separate measures that are being tracked. The first is patients 18 and older with a complete lipid profile performed during the measurement period. Again, a very limited population since your report period is only 90 days this year. And those patients 18 years and older who has on the most recent LDL-C level performed during the measurement period is less than 100 milligrams. Diagnosis, of course, tracked in the Diagnosis tab in the Encounter, or then the Problem List in the RxDX List tab. Very similar denominator tracking, so it's either patients with the IVD diagnosis or who were discharged alive after for acute myocardial infarction, coronary artery bypass graft, or percutaneous coronary interventions in the 12 months prior to the measurement period. The numerator is those patients who have a complete lipid profile performed during the measurement period, so that 90 days at the end of the year, and whose LDL-C was adequately controlled, okay, during that measurement period, again, at the end of the year. The improvement notation for this measure is that higher percentage indicates better quality of care, and those labs are both tracked by LOINC code, as we keep mentioning, which are set up for your orders in your orders list and clinic setup. Okay. So for your lipid panel, we'd be looking for the appropriate LOINC codes attached to it. And specifically, the LOINC code associated with the LDL-C. Next measure, CMS 157, PQRS number 143, oncology, medical and radiation, pain intensity quantified. This is the percentage of patients, regardless of age, with a diagnosis of cancer currently receiving chemotherapy or radiation therapy in which pain intensity is quantified. The pain intensity levels are documented in the Vital Signs tab in either one of these pain ratings. So any one of these is sufficient. Next measure. CMS 132, PQRS number 192. It's for your cataract patients. Complications within 30 days following cataract surgery that requires additional surgical procedures. Specifically tracking patients 18 years and older with a diagnosis of uncomplicated cataract who had cataract surgery and had any one of the specified list of surgical procedures in the 30 days following cataract surgery, which would indicate the occurrence of any one of the following major complications: retained nuclear fragments, endophthalmitis, dislocated or wrong power IOL, retinal detachment, or wound dehiscence. The improvement notation for this measure is that a lower percentage indicates better quality. Procedures performed in that 30-day period include excision of adhesions, lens procedure, paracentesis procedures, removal procedures of any kind that relating to the eye, retinal repair, revision procedures, scleral procedures, and vitreous procedures. Oops. Excuse me. The last measure to be covered today, and again, some of these will all be covered, these last three will be covered on Thursday's webinar if you choose to attend that one separately. CMS 147, PQRS number 110, preventative care and screening influenza immunizations. This is a carryover to the original quality measures that were first introduced in 2011. This is percentage of patients aged 6 months and older seen for a visit between October 1 and March 31, that's defined as the flu season, who received an influenza immunization who reported previous receipt of an influenza immunization. Those immunizations are tracked by the specific CVX codes for your immunization orders that are in your clinic setup list. It's your list of immunizations and clinic setup, and attaching the appropriate immunization code to the order. Okay. You'll notice that some of these are displayed in red. That means it's no longer active. So if you have a CVX code that's attached to one of your immunization orders and it's displayed in red, that's an indication that it's no longer active and you need to update your CVX code mapping. Again, so this report isn't necessarily looking for your free text influenza immunization that's been given, but rather the specific CVX code attached to it. To document the immunization, You would just simply add it in your order entry list, which would then populate in your immunization tab. Okay. Fill in the required information. If you've mapped the manufacturer code information to the order, that will pre-populate. Enter lot number, expiration, age, location where you gave it. Complete the vaccine. If the patient received the influenza shot at, say, the clinic and not in your office, you would document that they did, in fact, receive it by marking this pre-existing vaccine checkbox. Okay? And that covers all of the remaining clinical quality measures that we have in ClinicsMD. Again, the last three that we covered today will also be covered in the session on Thursday, and those are CMS 157, CMS 132, and CMS 147. But for interest of time, I went ahead and included them in today's session. So if you are signed up for Thursday's webinar, the three quality measures that will be covered, we have gone over today, so you can go ahead and skip Thursday's session. Okay. I'm now going to open up the floor to your questions. Again, using the question tool built into the webinar menu on the right-hand side of your screen. Enter in as many questions as you like. I'll give you 5 minutes to get them all in, and then I'll answer them one at a time for you. Okay, looks like we've got a few questions here to go through. First question is, do you know if Quest and LabCorp send the LOINC codes, and are they automatically included with those orders in ClinicsMD? That way you don't have to go back and manually enter those. As of Friday last week, the most recent files we've received from our Quest and LabCorp vendors, they are not sending this data in their lab results files that they're sending to us. I'm in communication with Quest and working on LabCorp next to see if they will be adding this information. It was supposed to be included as part of the changes for the 2014 certification specific to HL7 lab result messages, the updated format that became available in this 2014 certification, and it doesn't seem to have been adopted by all the labs yet. Jokingly referred to as the non-standard standard. So at this time, they are not sending this data over, but I'm working with the vendors one-on-one to see when they will be changing this and including it in their data they're sending. Next question. Please go over how the numerator and denominator criterions are documented in ClinicsMD for CMS 132 cataracts. The active diagnosis of uncomplicated cataract is documented via the Diagnosis tab in ClinicsMD or in the Problem List tab in the, Problem List within the RxDX List tab. Specific procedures performed are documented via either CPT codes or SNOMED codes based on the procedure. For instance, removal procedures. And they kept it very vague. So I apologize for that. They didn't list out specific removal procedures. But using the value set search tool that we have available, removal procedures are tracked by these CPT codes or these SNOMED codes. So in ClinicsMD, you would either record the CPT code to indicate that this procedure was performed or attach it to a specific ICD code, the SNOMED to ICD mapping that's available. Retinal repair procedures are documented much the same way, either by specific CPT code or by SNOMED code that you would map to an ICD-9 code, and so on. They do have an extensive list of exclusions, denominator exclusions available for this measure, and they are all listed in the specifications for CMS 132. They are patients with acute and subacute iridocytosis. I can't even say that word, so bear with me as I chop it up. Iridocytosis. Again, forgive me, I butchered that word. Adhesions and disruptions of iris and ciliary body, central corneal ulcer, burn confined to eye and adnexia, pseudoexfoliation syndrome, senile cataract, hypotony of eye, cataracts secondary to ocular disorders, high hyperopia, injury to optic nerve and pathways, congenital cataract, cysts of the iris, ciliary body, or anterior chamber, glaucoma, mature or hypermature cataract, traumatic cataract, posterior polar cataract, pathologic myopia, opened wounds, certain types of iridocytitis. Again, I butchered that word. I apologize. Vascular disorders of iris and ciliary body, hereditary corneal dystrophies, anophthalmosis, uveitis, chronic iridocytitis, corneal opacity and other disorders of the cornea, cloudy cornea, posterior lentoconus, aphakia and other disorders of the lens, corneal edema, retrolental fibroplasias, patients that are on systemic sympathetic alpha-1A antagonist medication for treatment of prostatic hypertrophy, or anomalies of pupillary function. So if your patients have any of those diagnoses or that medication, they would be excluded from the denominator of this measure automatically. Okay? Next question. If we document a pre-existing immunization, do we have to fill out the various fields such as location, etc.? If yes, we may not have that information as it was administered somewhere else. If no, would immunization registries receive this record correctly? They do require that you document as much information as possible when you're documenting your pre-existing immunizations. It depends on the immunization registry and specifically what they require. Again, it's one of those standards where there's a lot of leniency based on the state requirements. So one state may have it a required field, and another state would have it as a non-required field. Manufacturer information you don't need to record, lot number, lot expiration. All that information you do not need to record for a pre-existing vaccine. You do need to enter the patient's age, location, and route, and completed date if known. Next question, when will the recorded classes be available for reviewing? They are already available under the training link in ClinicsMD. It takes you straight to our training page on our website. Displays the full training schedule. And then the videos themselves are being uploaded to our channel on YouTube. So as you can see, all the sessions we've done to date are available. And we'll be adding to this as we go along, including other training sessions in ClinicsMD. So those are already uploaded and available. The one from today and then the short one that I'll have on Thursday will be uploaded by the end of the week. Final question, where do we record procedure codes in ClinicsMD, under CPT section or diagnosis tab or under orders procedures? Procedure codes are CPT codes, and they are added to the encounter in the diagnosis tab along with your ICD codes. You can, of course, attach CPT codes to your procedure orders in ClinicsMD to aid in your documentation and correct reporting. Correct code recording. To do so, you would enter the procedure order here and attach the CPT code order here. This is only useful if you're actually going to be performing the procedure in-house, as the CPT code isn't added to the encounter until the procedure order is completed, which if you're not doing it in-house, you wouldn't indicate that it was completed and charged out for it. But as a shortcut to documentation and charge entry, you can attach your procedure codes, the CPT codes, to your procedure orders in your orders list and clinic setup. Okay, doesn't look like we have any more questions for today. If you think of any after today's webinar, please feel free to send them to me directly. I can be reached at mary.brunson@clinicsmd.com. That information should have been included in the original invitation you received from us. So again, feel free to shoot me any questions you have after today's session. I greatly appreciate everyone for attending. I hope you found this very informative and useful, and look forward to working with you all later as we continue on the process of Meaningful Use Stage 2. Thanks, everyone, and have a great day.